Okay, so why don't we get started? I was just trying to put the PowerPoint slides for this up on Canvas, that the file size is too large, but essentially this is the same thing as the board review handout. I'll be pretty strictly going through that. So if you have the PDF, the Word document there, that's what we'll be using. All right, so this will be a really quick run through. So if I say something just like that is horribly wrong, raise your hand, but otherwise, to get through this, not a lot of questions. We'll have a little bit of time for that in between. All right, so the bird's eye view. Remember that when we think about the nervous system, we have our neuroaxis. And so we want to be able to start with the cortex and work our way down to subcortical, which would include white matter and basal ganglia, brainstem, cranial nerve, cerebellum, spinal cord, and then anterior horn cell, nerve roots, that includes the cauda equina, plexus, a brachial and a lumbosacral, peripheral nerve, and then neuromuscular junction and muscle. Okay, so remember, just a lot of things, neurologic complaints can fit into many of these categories. Weakness is a great example. Cortex all the way down to muscle can cause cortical lesions, or muscle lesions can cause weakness. And so we need to have some way of trying to organize this. So up here in white, we have where the upper motor neurons are located. All right, so a cortical, subcortical, brainstem, or spinal cord lesion would all give upper motor neuron findings. Okay, we'll list those in just a little bit. Some asterisks here by basal ganglia. Diseases or lesions of the basal ganglia, you don't tend to get upper motor neuron findings, but you get a movement disorder. Okay, and the other exception here is, of course, cerebellar lesions, which you wouldn't associate with upper motor neuron findings, but rather ataxia, nystagmus, vertigo, and so on. Okay, in yellow we have our lower motor neurons. Okay, so if you see atrophy and a loss of reflexes, and we'll list the other lower motor neuron findings, then your lesion has to be here, either the anterior horn cell, nerve roots or cauda equina, plexus lesions, or peripheral nerve. That's it. Okay, and then out here at the neuromuscular junction or muscle, so these patients will have weakness and other findings, but these don't involve upper or lower motor neurons. Okay, so we're not going to have upper or lower motor neuron findings. Well, with the exception of severe muscle disease after a long period of time, there may be, some atrophy, but for the most part, no upper or lower motor neuron findings. Okay, remember, neuromuscular junction conditions classically have fatiguing weakness, and muscle diseases classically have proximal muscle weakness. Okay, so that's the big picture. So here are the upper and lower motor neuron findings. So really something you have to have down. So of course, hyperreflexia is seen in upper motor neuron lesions. You lose reflexes with anything lower motor neuron. Remember, like Guillain-Barré syndrome, where the reflexes are absent. Of course, our Babinski sign, the upgoing toe, is an upper motor neuron finding. Tone is increased in upper motor neuron lesions. So this is why we call it a spastic weakness. Okay, in a lower motor neuron condition, we have no tone, a floppy, flaccid weakness. Okay, atrophy is prominent with lower motor neuron conditions, not with upper motor neuron. And fasciculations is with anything lower motor neuron, classically anterior horn cell lesions, but anything lower motor neuron could do that. And then if we're in the EMG lab and we put a needle in the muscle, we would see fibrillations as a finding of lower motor neuron pathology. Just an asterisk here to remind you that the other thing that will give you increased tone would be like Parkinson's disease. But remember the difference between spastic increased tone and rigidity. So upper motor neuron lesions, the increased tone is velocity dependent. There's that catch when you move the limb. Rigidity is not velocity dependent. So if you have someone with Parkinsonism and the arm is stiff, doesn't matter how fast or slow you move the limb, there's increased tone. Okay, and then there's this other condition we talked about last year, Myotonia. That would be something like Alzheimer's disease, where you're trying to check muscle tone and the patient is resisting you. So several things other than spasticity can cause an apparent increase in tone. All right, so let's start quickly here with muscle diseases, just like we did at the beginning of the course. So remember, most of your muscle diseases have proximal weakness as the classic feature. So proximal weakness, it's going to be hard to walk upstairs. Lifting your arms above your head is mainly a function of the proximal muscles, so that's going to be difficult. Some of these patients will have aches and pains in the muscle as well. And remember that any time we have an active breakdown in muscle, our creatine kinase muscle enzyme will be elevated. Okay, so we talked about the inflammatory myopathies where it's rather subacute over weeks. Again, more proximal, sometimes muscle pain, and a significantly elevated creatine kinase. And dermatomyositis, of course, has the specific features that polymyositis lacks. So you get the classic rash in the cheek area, the eyelids, sometimes with swelling around the eyes, periorbital edema. And then, of course, we've got the pathognomonic finding at muscle biopsy, perifascicular atrophy. You can see the atrophy out here peripherally. Okay, so we can nail down the diagnosis of dermatomyositis. Polymyositis, we exclude other conditions, and then we conclude that this must be polymyositis. Inclusion body and myositis, very different. These are older men that have weakness in two muscle groups, quadriceps and finger flexors. Okay, so that's very unique. It's not treatable like poly and dermatomyositis that both respond really well to steroids, so unfortunately no treatment for this. Dysphagia is a bit more common with inclusion body myositis. Okay, other big category we talked about were the muscular dystrophies. So definitely the one you're asked about most often is Duchenne's muscular dystrophy. And so, of course, this is X-linked recessive, which means it's young boys that develop the symptoms. Women are carriers. And so this is quite rapidly progressive, usually death by mid-teens or 20s. So you want to have a few things clinically that would jump out at you. First of all, we have a young boy that has a walking problem. Oftentimes there's a lot of scoliosis and lordosis, and of course, calf hypertrophy. It's just something, you see that in a vignette, it's going to be Duchenne's if it's a boy who's weak. Okay, remember they have a classic way of rising from the floor. Any patient with severe proximal weakness will rise from a floor this way, so it's not specific, but the Gower's sign we'd classically associate with Duchenne's. So to rise from the floor, they use their plantar flexion, which is relatively strong, so they'll use their tiptoes, and then they'll use their hands to kind of walk up their legs. Okay, that's the Gower's sign. Okay, calf hypertrophy, don't forget that. So generally they're able to walk until the age of 10, and by that point they need leg braces to walk, and then usually wheelchair by 12. And you know, this is a fairly predictable course, so most patients will die around age 20 from respiratory failure. So remember, we call Duchenne's and Becker's both dystrophinopathies, and it's really kind of a spectrum depending on how much dystrophin is present or absent. So dystrophin here, an important link between muscle and the sarcolemma membrane. So if we don't have dystrophin, the muscle breaks down very easily. Okay, myotonic dystrophy is the adult onset muscular dystrophy that's most common. And so even though by and large the muscle diseases have proximal weakness, here is a common muscle disease where it's distal weakness. Okay, so these patients often will present with a foot drop, for example. Okay, they have the classic facial appearance. So if you are shown a picture with a lot of atrophy of the temporalis muscle, droopy eyelids, kind of an open mouth, inability to smile, glum facial expression, that's what we see. Frontal balding, really common also. Okay, and of course myotonic dystrophy reflects the myotonia. So you can elicit this on exam by having the patient to squeeze your fingers tightly, they can't let go. And you can have the patient close their eyes tightly and they can't just immediately open them up. It takes them a while to kind of pry the eyelids open. And the other thing we like to do on exam is if you just tap muscles, it triggers them to go into myotonia. So the one we usually do is tapping here on the thumb. You tap there and the thumb elevates and it stays like that for a few seconds and then relaxes. That's myotonia. You can even tap the tongue and trigger focal myotonia there. Okay, so remember that this has all of the other non-muscular manifestations. So very significant, you know, if you're a family practice doctor and you've got one of these patients, to be aware of the cardiac conduction disturbance. It can be life-threatening. So frontal-balding cataracts are almost universal in patients with myotonic dystrophy. And so the picture here that hopefully helps you remember all the different things from the distal weakness, cardiac conduction, facial appearance, and cataracts. All right, so this is the first of several trinucleotide repeat conditions that we'll mention here. This is autosomal dominant. Usually not hard to diagnose because so many other family members have it, and they usually come in knowing what they have. Okay, and then just briefly some iatrogenic myopathies where we do it to the patient. So the statins, the HMG-CoA reductase inhibitors, very commonly prescribed group of medications. Usually weakness is not the major feature here. It's more of a myalgia, muscle pain, and you check a CK and it's elevated. It goes away when you stop the medication. Remember AZT used in the treatment of HIV can cause an inflammatory myopathy. And chronic steroid use, among all of its other long list of side effects, one big downside to having patients on chronic steroids is that it can cause some weakness of proximal muscles. Okay, neuromuscular junction. There are three most common neuromuscular junction conditions you need to be very comfortable with. The first here is with the voltage-gated calcium channels, so that's Lambert-Eaton syndrome. We have antibodies against these voltage-gated calcium channels. Next is a problem with release here of acetylcholine via dysfunction of the snare proteins, that's botulism. And then out here on the nicotinic receptors, antibodies that form here causes myasthenia gravis. So two are a problem with presynaptic release and one is out on the nicotinic receptor. And that's just really important because when you think about myasthenia then, these patients are only allowed to have weakness. Nothing else, right? Because the only problem is the nicotinic receptors on muscle. So they're not going to have autonomic dysfunction, dry mouth, all of that. If you're not releasing acetylcholine, then you're affecting not only neuromuscular junctions, but also acetylcholine that's involved with the parasympathetic system and all of the muscarinic receptors. Okay, so remember the normal physiology here of acetylcholine release, and many other neurotransmitters have the same mechanism. So you have the acetylcholine bound up in these vesicles, and so the key event is the entry of calcium, which kind of breaks these vesicles apart, so that when the calcium binds to synaptotagmin here, that causes the fusion with the snare proteins and the synaptic vesicle. And then we have release of acetylcholine. So in myasthenia gravis, antibodies against nicotinic receptors, so it usually presents with an ocular manifestation. So the initial presentation is droopy eyelids and double vision, usually. Okay, so patients come in looking like this, and it's fatiguing. So you have the patient look up at the ceiling, and after a few seconds, the eyelid kind of drops down. That's the curtain sign. Or you have the patient follow your finger. And after watching the patient move back and forth, suddenly one eye isn't moving anymore. So that's a fatiguing weakness. Okay, the pupil is never involved because the third nerve that constricts the pupil does so via muscarinic receptors, right? So pupil is normal in myasthenia. Okay, we have neuromuscular junctions for swallowing. And so often patients will have bulbar symptoms. Remember, that's dysarthria and dysphagia. And extremity weakness usually occurs as well, so some fatiguing weakness in the arms and legs. So again, want to bring that out on exam. Don't just give one push, but keep pushing down so you can overcome, you can fatigue the neuromuscular junction. All right, so diagnosis. Well, we like to do a tensilon test, acetylcholinesterase inhibitors. So you get a brief increase in acetylcholine. So more nicotinic receptors are stimulated and the patient often gets dramatically better. Very quick thing to do, very safe, is just an ice pack test. Put ice on the eyelid for a minute or two, and cool temperature actually inhibits the acetylcholinesterase enzyme. Oops. In the EMG lab, if we repetitively stimulate a nerve, you get this decremental response. So if you ever see anything like that, it's myasthenia, definitely. So normally nothing should happen. The waveform should stay the same. And then we've got a great blood test. You can measure the antibody that forms against the nicotinic receptors. So very important, once we diagnose someone with myasthenia, we always have to look for a thymoma. Remember that that's where the immune system learns to recognize the nicotinic receptors as foreign. So we do a chest CT. Okay, and there's a lot to the treatment of myasthenia, but I think really all you need to know for right now is pyridostigmine, which is a long-acting acetylcholinesterase inhibitor. Okay, oops, sorry. And so that helps with the weakness, but remember you're also going to have now more acetylcholine stimulating the parasympathetic system. So the most common side effects then would be stomach cramps and diarrhea. Okay, too much vagus nerve stimulation of the gut. Okay, so botulism. Now again, the problem is not with enough release of acetylcholine. So we're going to understimulate nicotinics. That causes weakness, and this tends to be a descending paralysis. Okay, remember Guillain-Barré, there's a lot of overlap between botulism and Guillain-Barré, but Guillain-Barré is usually an ascending paralysis. So it usually starts with the eyes, then the bulbar, and then the arms and legs. So often get profoundly weak, and understimulation of muscarinic receptors then, and again, why are these the two that are usually affected? I don't have a good answer, but it's usually the pupil. Okay, so you lose that third nerve supply to the pupil, so the pupil is usually very large in patients with botulism, and the GI tract is especially involved, so constipation is a big complaint. All right, so remember botulism, you know, if the story is a whole family that comes to the emergency room after eating a potluck or you know, some meal with canned goods, that's going to be botulism. And of course in this area we see a lot of it from heroin use from Mexico. Okay, so again, what's the mechanism here? In botulism, you have disruption of the snare proteins. So there's no problem out here with the nicotinic receptors. Okay, the acetylcholine is just not released. Okay, now this is not a neuromuscular junction problem, but just as long as we're talking about how neurotransmitters get released, the same mechanism for glycine in the spinal cord. Okay, and so I'll just mention here, tetanus actually cleaves the synaptobrevin here. So why is the tone increased and all the spasms that are part of tetanus? It's because we're not having a release of glycine in the spinal cord. That's an inhibitory neurotransmitter, and so there's much more excitatory output from anterior horn cells to muscles in the arms and legs. Okay, not a neuromuscular junction condition, but it kind of ties into what we're talking about here, release of neurotransmitters. Okay, Lambert-Eaton syndrome, remember now, is antibodies against voltage-gated calcium channels. This is paraneoplastic, and so it's usually, the story is going to be a smoker because most of it is lung cancer. Okay, and so again, kind of like botulism, I mean, night and day presentation, but it's when we don't release acetylcholine, you don't stimulate nicotinics, that gives weakness. And in Lambert-Eaton, it just tends to be the legs. So it's usually kind of slowly progressive leg weakness. You don't stimulate muscarinics. And in the case of Lambert-Eaton, that tends to be the muscarinics for the salivary glands and the GI tract. So leg weakness, dry mouth, constipation, an older man who's smoking, that would kind of be your perfect storm here for Lambert-Eaton syndrome. Okay, now Lambert-Eaton syndrome, when you knock out those voltage-gated calcium channels, those seem to be important for facilitating reflexes on exams. So these patients generally don't have reflexes. This is not a lower motor neuron problem, but it just has to do with the physiology there at the neuromuscular junction. They have leg weakness, tends to be more proximal. So this isn't an easy diagnosis, but this is the one thing, if you see it, you know for sure this is Lambert-Eaton syndrome. So briefly have the patient activate the muscle, which for just a few seconds overcomes what's going on with the voltage-gated calcium channels. You get an influx of calcium, and so the reflexes miraculously return for a few seconds. The strength gets better for a few seconds, and then it goes right back to baseline. Okay, so exercise facilitation is unique to Lambert-Eaton syndrome. Okay, again, diagnosis here. We've got a great antibody, very sensitive, very specific. So we check for a voltage-gated calcium channel antibody, can make the diagnosis. And now when we do EMG, remember myasthenia, we get a decremental response. In Lambert-Eaton syndrome and also in botulism, in both of the presynaptic conditions, we can get an incremental response where the waveforms actually increase. Okay, so the medication for Lambert-Eaton syndrome you need to know is 3,4-diaminopyridine, and the action here is it blocks potassium channels, and that has the function of prolonging the action potential as it's going down and stimulating the voltage-gated calcium channels. So we get more calcium influx. Okay, so this is a good time just to review a little bit here about autonomic nervous system versus somatic neurons. All right, so remember our lower motor neurons in the spinal cord are anterior horn cells. Okay, but a lower motor neuron is just a nerve that talks directly to muscle. So you've got lots of lower motor neurons in the brain stem as well. Okay, 3, 4, 6, 7, 9 through 12. Those are all cranial nerves that are supplying muscles. All right, so we either have cranial nerves, or in the case of anterior horn cells, this goes through roots, plexus, peripheral nerve, and then we have release of acetylcholine, and again on nicotinic receptors. And kind of arbitrarily here, we call them N1 receptors. All right, contrast with parasympathetics, which are here on the left. And so these are craniosacral. Okay, so certain cranial nerves have parasympathetic function, and then sacral, mainly for bowel and bladder function. And so here we have a preganglionic fiber which goes out to a ganglion. And so this is acetylcholine, but again, very important here, it's a different nicotinic receptor. So these are not involved in myasthenia gravis. Okay, and the neurotransmitter then on target organs for the parasympathetic system is a muscarinic receptor. Okay, so again, parasympathetics rest and digest. So we're going to constrict the pupil, stimulate the salivary gland and the GI tract, slow the heart rate down. This is not fight or flight, so rather than relaxing the bronchi, there's constriction, and again, stimulating the GI tract and emptying the bladder. Okay, so I highlighted here the ones by name that I thought would be just important to know. So we've said that if you don't have release of enough acetylcholine like you do in Lambert-Eaton or botulism, you're going to potentially have lots of parasympathetic dysfunction. So remember that both of these excuse me, will affect here the vagus nerve and the dorsal motor nucleus. So constipation is a big problem with both of these. In the case of Lambert-Eaton syndrome, you affect the salivary glands, and so dry mouth is really common. So I think just by name, I would be sure to know that for the third nerve, the Edinger-Westphal nucleus is the one that's involved here then via the ciliary ganglion in constricting the pupil. And the other one I would know by name for sure is the dorsal motor nucleus. So when you hear that nucleus, you want to think parasympathetic function of the vagus nerve. Okay, so atropine is a medication that blocks muscarinic receptors. Okay, so if you were asked what's going to happen when you give atropine, well, you would just need to know, okay, 3, 7, 9, 10, those are the cranial nerves that could all be knocked out. So rather than, constricting the pupil, they might have a large pupil. Certainly dry mouth via the effects on 7 and 9, constipation, urinary retention. So these would be the potential side effects of either giving atropine or tricyclic antidepressants, which although they work great for various pain syndromes, the big downside is all of the anticholinergic side effects. All right, so the sympathetics here, of course, also the preganglionic fiber and ganglion, it's acetylcholine nicotinic, but now the N2 receptor. But now out here on the target tissue, it's predominantly norepinephrine and some epinephrine if we're talking about the adrenal medulla. Okay, so it's just the opposite, of course, of what the parasympathetic system is doing. But really important here, the one exception is that sweat glands are supplied by the sympathetics, but they utilize acetylcholine and muscarinic receptors. Okay, so again, if we go back here to things like atropine and tricyclic antidepressants that act against muscarinic receptors, well, you could also have dry skin from those medications, but that effect would be against the sympathetics. Okay, so again, tricyclic antidepressants, they're listed later in your handout, but nortriptyline and amitriptyline are the two that are used frequently, and so that would target the muscarinic receptors. All right, something else that is neuromuscular junction would be organophosphate exposure. So this is generally going to be farmers that have insecticide exposure, and so this inhibits the acetylcholinesterase enzyme, so you have much more acetylcholine now, both at neuromuscular junctions and also at parasympathetic muscarinic junctions. And so in terms of the peripheral muscarinic stimulation, okay, if the dumbbells mnemonic helps, okay, so you stimulate the GI tract, and so oftentimes there's going to be defecation, diarrhea. You stimulate the salivary glands. These patients are just going to be coming in drooling, eyes tearing. If you remember, there are muscarinic receptors in the brain, acetylcholine, and so these patients often have confusion, and sometimes that can be very severe, even coma, from the central muscarinic stimulation. Okay, and as you know, if you bombard nicotinic receptors, you don't get super strong. You knock them out. Okay, and so weakness then is a feature. These patients usually have quite profound weakness. Okay, so it's the combination of the muscarinic stimulation, nicotinic stimulation, but usually I think what kind of gives it away on a vignette is an acute presentation with just a lot of salivation. That's going to be part of probably any presentation. All right, peripheral neuropathy. So here's a little mnemonic, and I've never known actually, is it dang therapist or dang the rapist? Because either way it actually works. But someone gave this to me a long time ago, and I've used it, but I never know which was originally intended. So anyway, the first two here are diabetes. Of course, that's far and away the most common cause of peripheral neuropathy. Alcoholism, chronic alcohol use, another very common cause. Nutritional, B12 deficiency especially. So remember, these patients get a small fiber neuropathy, but more importantly is that you associate B12 deficiency with the spinal cord, posterior column dysfunction especially. Okay, Guillain-Barré syndrome, probably the most common peripheral neuropathy you'll be asked about on board, so I'll go into that here in just a few minutes. Trauma would include all the entrapment neuropathies, carpal tunnel syndrome, ulnar neuropathy, peroneal neuropathy that we'll talk about in just a few minutes. I think probably the only hereditary peripheral neuropathy you should know about is Charcot-Marie tooth. So autosomal dominant typically, lots of family members have this. It's chronic and a little bit unique because it tends to be more of a motor neuropathy. So if you see a patient with Charcot-Marie tooth, they usually have significant atrophy below the knees and usually a foot drop. And anytime you have a very chronic, severe motor neuropathy, the toes tend to pull up like this, so we call these hammer toes, and usually patients have very high-arched feet as part of that. Okay, and you can do a genetics test to prove the diagnosis. Endocrine, probably the most important one here would be hypothyroidism. Okay, and so hypothyroidism has a bunch of different presenting symptoms, but one would be numb stocking glove, numb toes, numb feet. Remember, that's how most 95% of peripheral neuropathies present. It's distal, starts in the toes, then in the fingertips. And so hypothyroidism, the patient may also complain of a cold intolerance or dry skin, constipation, fatigue, more systemic kind of complaints in addition to the neuropathy. So easy to diagnose, just check a thyroid function. In rheumatologic, mononeuritis multiplex, remember this is a vasculitis that affects the peripheral nervous system. So it's really like strokes of individual nerves. So the key thing here is we don't have it now a symmetrical stocking glove presentation. We now have a patient with a right peroneal neuropathy and a left median neuropathy. Distinctly individual nerves picked off, everything else is normal. Okay, these patients are usually sick. They usually have a lot of other things going on. Kidney failure, skin lesions, so it's not only the nerves that are affected. Okay, we didn't talk about amyloid, but you know, it just would spoil the nice here mnemonic, so we'll leave that in. Porphyria, remember this has an acute presentation, often triggered by sulfonamide or other medications, and the patient comes in kind of looking like Guillain-Barré syndrome, okay, often with a profound weakness. We talked about HIV is probably the most common infectious condition that would cause a peripheral neuropathy. Okay, we didn't talk about sarcoid, but some toxins here that I think you should know about, especially phenytoin. Remember, a commonly prescribed anticonvulsant that causes peripheral neuropathy. Okay, if you don't give B6 with INH, then that can cause a peripheral neuropathy. Lots of chemotherapeutic medications, and really the one you should know is vincristine. Okay, vincristine, remember, is unique because it affects the microtubules and it affects axonal transport. The mechanism is so well known that that's one specific medication worth knowing. Arsenic, remember, arsenic has two very different presentations for peripheral neuropathy. If we get acute, profound exposure, then it's severe weakness, like Guillain-Barré syndrome. Okay, but usually with a lot of GI complaints, patients throwing up. If we have more of a low-level exposure, the patient's drinking well water or taking some medication from another country that has arsenic in it, something like that, now we just get the stocking glove, numb toes, numb fingertips. And these are the patients that may have the Mies lines. Okay, remember lead exposure. I think I didn't actually show you my patient who works in a gun shop and got lead exposure from that. That can cause peripheral neuropathy. And remember that it can affect perhaps the radial nerve out of proportion. Okay, so mechanisms to know. I think two for sure. One would be diabetes. You need to know the mechanism of peripheral neuropathy, which mainly involves two things. It's a microangiopathy, so you affect the small blood vessels that are very important to supply the peripheral nerves, but also the hyperglycemia, especially with conversion to sorbitol, leads to osmotic changes within the axons and the Schwann cells. So it's a kind of a combination of things here for diabetic neuropathy. And I mentioned you need to know the mechanism here for vincristine and neuropathy. All right, Guillain-Barré syndrome. So remember, it has this distinctive presentation of an acute flaccid paralysis. And so the mechanism is demyelination of the peripheral nervous system. Okay, so remember, 2/3 of patients will have had a cold or a virus, or in the case of Campylobacter, the one you should associate with Guillain-Barré, it's a diarrheal illness. So they recover from that, and then a few weeks later, they come down with the symptoms of Guillain-Barré. Okay, so in contrast to botulism, this starts in the legs usually and works its way up. It's an ascending paralysis that patients are usually in the emergency room within a rather short period of time. So again, it's peripheral nerves, plexus, nerve roots, everything that's peripherally myelinated is affected. So we should have only lower motor neuron findings in Guillain-Barré. And the reflexes are gone in almost all patients. Can't get reflexes. All right, remember that our cranial nerves, 3 through 12, are also myelinated by Schwann cells, right? So any cranial nerve, 3 through 12, can be affected, but it's usually cranial nerve 7. So patients with Guillain-Barré usually have what looks like a bilateral Bell's palsy. Okay, so patients tend to get worse, and usually by the 2nd or the 3rd week, they turn the corner and they get a lot better. Okay, so but remember, the biggest concern in patients with Guillain-Barré is respiratory failure. 1 out of 4 patients will lose the ability to breathe on their own. So that's what you want to monitor for. Get them intubated before they stop breathing. Okay, so this is a demyelinating condition. So remember, the large sensory fibers that are myelinated convey vibration and proprioception. So patients with Guillain-Barré lose vibration, proprioception, not pain and temperature. So the big distinction between those two. Okay, and the autonomic nerves are involved in Guillain-Barré syndrome. So there's often a lot of autonomic instability, blood pressure fluctuations, and that's a little hard to explain, but it's just there. Okay, so how do you make the diagnosis? Well, you do a lumbar puncture, and you get this very high protein, but not elevated inflammatory cells. So the albuminocytologic dissociation. Okay, that doesn't tell you they have Guillain-Barré, it's just consistent with it. Okay, and then you do an EMG, and so the pathophysiology of Guillain-Barré is multiple segments, focal segments of demyelination. And so from a physiologic perspective, that's conduction block. Okay, so conduction block is what you're looking for here to confirm Guillain-Barré. All right, so boards usually will contrast in some way between Guillain-Barré and multiple sclerosis, because remember, multiple sclerosis is central nervous system demyelination. So you just need to know what is myelinated by oligodendrocytes, what's myelinated by Schwann cells. So, of course, oligodendrocytes is the whole brain and the spinal cord, right, and the optic nerve. That's the important one to kind of contrast with Guillain-Barré syndrome. So if you've got optic neuritis, it's not Guillain-Barré, but it certainly could be multiple sclerosis. All right, so the entrapment neuropathies, these are all very frequently asked. Carpal tunnel syndrome, remember median neuropathy at the wrist, so it's a numb hand. Okay, classically digits 1 to 3 and then half of the fourth digit, but in the real world, patients just say my whole hand is numb. So if you had to ask one question, it would be, when does it bother you? So nocturnal awakening is the key feature in carpal tunnel. And remember, the muscle that goes through the carpal tunnel that can be affected is the abductor pollicis brevis, which is right out here in the lateral thenar eminence. So we often see atrophy right there of that muscle. Ulnar neuropathy. Ulnar nerve is almost always damaged at the elbow. So patients like in a wheelchair that are resting their arm all the time on something, that irritates the ulnar nerve. And so in contrast to carpal tunnel, the main complaint now is usually my hand is weak, because you lose the supply to so many ulnar muscles. Okay, and I knew there was going to be something technical. There we go. And so ulnar neuropathy, remember a couple of good ulnar muscles here. One is the first dorsal interosseous. We've talked about that quite a bit for abduction of the index finger. So that's going to be atrophic in ulnar neuropathy. And we'll go over some of the other ulnar muscles here in just a few minutes. Okay, radial neuropathy, of course, finger drop, wrist drop. Okay, the Saturday night palsy would be the most common situation. Someone falls asleep with the arm in an unusual position. So it's usually at the spiral groove. And remember, the key thing with radial neuropathy is the triceps, even though it's supplied by the radial nerve, comes off before the spiral groove. So triceps is usually normal in a radial neuropathy. Okay, peroneal neuropathy, I'm going to show you a picture here in just a little bit. And axillary neuropathy, often trauma with shoulder fracture or dislocation. And so now that's going to affect ability to elevate the arm. And also there's usually a numb patch right here on the lateral shoulder area in axillary neuropathy. Okay, yeah, there it is. So that's the numbness you'll have with an axillary neuropathy. This will be easier to understand here when we get to the brachial plexus and can show why the numbness is here in a musculocutaneous neuropathy. But here's the numbness in a median neuropathy. Okay, ulnar neuropathy, it's mainly fourth and fifth digits. Radial neuropathy, the numbness is going to be in the dorsum of the arm and here into the back of the hand, dorsum of the hand, not so much on the anterior portion. All right, so the most common peroneal neuropathy, so remember this nerve is very superficial as it goes around the fibular head, and so leg crossing, like falling asleep with your legs crossed, something like that, usually damages the deep peroneal nerve right here. Okay, and so this supplies the tibialis anterior muscle. Okay, here are the nerve fibers, and that is the muscle that dorsiflexes your foot. So patients get up to walk and they have a foot drop, and usually they just have numbness here between the first and second toes. Now, if you have a lesion more proximally up here at the common peroneal nerve, a little further up, now you're also going to involve the nerve fibers out here, the superficial peroneal, and so that supplies eversion of the foot. So you'll have some weakness with that as well. And then the sensory loss is going to be more, broader here in the lateral shin area. So here's a good differential for foot drop. Peroneal neuropathy, the key thing is you just look for isolated weakness in a peroneal nerve distribution. So these would be the two most common causes. L5 radiculopathy. Now, one thing in the story would be helpful. If the patient's telling you they got severe back pain, shooting pain down the leg, then just that story would make you think radiculopathy is more likely. But if you just were limited to checking one muscle to tell the difference, I would choose foot inversion. Okay, and the reason is that's a strong L5 muscle inverting your foot, but the nerve is the tibial nerve. Okay, so if someone has a weakness with foot inversion, then it cannot be a peroneal neuropathy. So, because it's not supplied by the peroneal nerve. Okay, so again, with an L5 radiculopathy, the weakness is going to be a bit broader than just peroneal nerve distribution. Okay, ALS we'll talk about, but here, of course, we have a foot drop, but there's no sensory loss, and hopefully you find upper and lower motor neuron findings and fasciculations. We'll come to ALS in a minute. Peripheral neuropathy, like Charcot-Marie tooth I mentioned, would be a classic presentation with a foot drop. And peripheral neuropathies are, by and large, perfectly symmetrical. So now we've got not one foot, but both feet. You may have some stocking glove sensory loss, so even some hand involvement. Okay, and then myotonic dystrophy. Remember, it's distal weakness, but there's so much else that's going to point you in that direction, right? They've got myotonia, they've got the classic facial appearance, so that should stand out for you. All right, so nerve conduction studies in a nutshell. Remember when we are checking motor nerves, and the waveform you see is called the CMAP. And so anything that affects lower motor neurons, whether it's anterior horn cell, nerve root, plexus, or peripheral nerves, the nerve is going to degenerate. Well, they're in degeneration. And so the CMAPs are always going to drop in any lower motor neuron condition. Okay, the tricky thing here about the SNAPs, the sensory nerve action potentials, is that the same thing occurs. If you destroy peripheral nerves or plexus, the SNAPs are going to drop also. But the tricky thing to remember is if you have a lesion at the root level, okay, or something like in the spinal cord, like ALS, well, in the case of radiculopathy, the nerve roots are compressed prior, or proximal, I should say, to the dorsal root ganglion. So the dorsal root ganglion then maintains the health of the whole peripheral distal part of the nerve. So the SNAPs are normal, even though the patient has sensory loss and pain, but the lesion's proximal to the dorsal root. So you get normal SNAPs with a radiculopathy. Okay, and I've seen boards ask, what do you see in carpal tunnel syndrome on nerve conduction study? And the right answer is prolonged distal latency. And what that means is if you're stimulating, remember you can stimulate the nerve, all the way up from the axilla down, but the distal latency is the most distal point of stimulation, and then we're recording that impulse as it travels down to the muscle, or maybe down to the thumb or the index finger. And so the distal latency is just a prolongation of that last, most distal point that we're measuring. Okay, EMG now, of course, we're putting needles in muscles, so you need to know the difference between a fibrillation and a fasciculation. Fibrillation is a single muscle fiber that has lost its nerve supply, and that can be an anterior horn cell lesion or a peripheral nerve lesion, but the muscle fiber is dying, and as it dies, it sends out a signal. That's a fibrillation. Okay, because it's only one muscle fiber, you can't see it clinically. You only can see it or hear it if you put a pin in the muscle. Fasciculations are the whole motor unit discharging, right? So that's why you can look at the skin and see fasciculations. So we see both on an EMG, but one important thing here is if you are given some scenario and there are lots of fibrillations on the EMG, that tells you there's active ongoing destruction of nerves, and often happens acutely. Okay, so we're concerned when we see fibrillations. Okay, next we have the patient activate the muscle. And so remember, a whole bunch of motor units then come into view. So this would be just a normal motor unit potential. If we have denervation with subsequent reinnervation, remember now each motor unit is much larger. There are fewer of them, but they're bigger. So if you have large motor unit potentials, this is a chronic condition now. So like someone with Charcot-Marie tooth, certainly. You put a needle in that muscle, they'd have giant motor unit potentials. So remember, fibs are acute. Large motor unit potentials take some time to develop. And then if we have a muscle disease, and now we just have a random dropout of muscle fibers, and so what we see now is very teeny tiny small motor unit potentials. Okay, this is a good, yeah, I can hear the groans here, the brachial plexus. So let's take just a really quick, like a little 5-minute break, and then we'll start up from here.